welcome to the meeting, everybody. And I'd just like to introduce our partner GP, Matt Sawyer, who's our expert guru in sustainability in general practice. So just to give you a bit of housekeeping, if you've got any questions, then you can raise your hand and we can answer it there and then. You can put it in the chat and we'll answer it at some point during the conversation as well. We have had quite a few questions submitted with the registrations, which is great. We'll try our best, or Matt will try his best, to answer them within the session or at the end of the session. But if anything does happen to be missed, we will answer them in the follow-up guide that we send after the session.
Thank you very, very much, Helen, and good afternoon and welcome to everyone. It is always a pleasure to have an hour of your time. So today really is an introduction to, not an absolutely comprehensive guide. Helen and others know that I will, and any of you who've met me before knows that I can speak on this for about 8 days without drawing breath. My wife is really grateful that I get to do these sorts of talks so that I don't talk to her incessantly about environmentally sustainable general practice and primary care. So this is very much an introduction. So if some of you may be further on in your journey than some of the details that I'm going to give you today, but this is a Basics 101. And the plan is, if there are things that you are interested in, that we can do more sessions on those. Personally, I'm happy to try and keep an eye on the chat at the same time as talk, but I'm going to try and do the presentation and then do the questions afterwards. So today it's really about, so I'm a GP by background, I live in North Yorkshire, and for me the big question is, how can we deliver high quality healthcare to the patients that we look after without causing environmental harm, and at the same time looking after our staff, their well-being, their morale and motivation, and making sure that we have got financially viable healthcare operations and businesses. So we're going to do all of that within an hour. So I'm going to try and cover these topics. So what is sustainability? What does that mean? We hear the word a lot, but is it actually what we think it is ourselves? It's not important to healthcare, is it? We look after patients. Sustainability, that's things that other people do. That's not us. What's this net zero thing I hear about? What must I do? You know, as a person who works within a practice or within healthcare or primary care. That's going to cost a lot of money though, isn't it? Surely these things, going green is expensive. Well, actually, I'm here to try and show you that the opposite is true. And also that this is not a burden. This is not about doing more work. This is about doing what we do anyway, but just doing it a bit differently, so we actually get better outcomes for our patients as well. But I'm going to start with a question. Well, what does sustainability mean to you? I'm just going to give you 20 seconds, and by all means, you can pop something in the chat if you would like, and I'm just going to try and open up the chat at the same time. So what does the word sustainability mean to you? Well, actually, I think that the word sustainability on its own is a little bit meaningless. I would far rather that we put an extra word in front of the word sustainability when we try and describe it. So I did a master's in environmental sustainability, and my dissertation was going and asking small businesses, what does sustainability mean to you? Not one single person mentioned the environment. Every business said it was about financial sustainability. Are they still going to be here next year? Can they pay their staff? Can they pay the wages? Or it's business sustainability. Can we continue to trade? Or it's staff sustainability. It's social sustainability. Are we still going to have enough people to be able to do it? So of all of the businesses that I asked, not one single one used the word environment, environmental, planetary, or anything else. So we've got to be very careful when we use this term and define it a little bit better than just sustainability, because otherwise we end up talking about different things. So I'm going to particularly be talking about environmental sustainability today, but there is also social sustainability of staff and patients, anything to do with people, and financial sustainability for practices and for people as well. One of the things that I talk about a lot is about carbon emissions, carbon footprints, and I'll talk about that in a little bit. But sustainability is far more than just carbon, just greenhouse gases, and just climate change. It's important. The world is changing. We can see weather patterns changing. We can see the climate changing in front of us. We can see the devastation that is causing to our patients around the world and in this country. If any of you have ever been flooded out or had your practice flooded out, you will know what the impact of changing weather has. But actually, there's a whole host of other things that are also important when it comes to planetary health and environmental sustainability. So yes, climate change will have the biggest impact over the next few decades, whether that be mass extinctions, crop failures, access to clean water. It will have a huge impact on how where people live and how people move. So we're actually looking at all of these different things together. So yes, I will talk a lot about the climate change aspect of it, but don't think that that's the only impact that we have when delivering healthcare. And we can start to see that these things have impacts on our patients. We look at starvation, gross inequalities, pandemics. We know that they have impacts on our patients. And that means that more patients end up coming through our doors. One of the impacts is from air pollution, and I'm going to pop into the chat this address so that people can have a look at what their air pollution is in the UK for your personal postcode. So this is, you put in your postcode and it tells you what your air quality is where you live, where you breathe, where you work, where your kids go to school, etc. And you can start to think, well, this isn't a problem that's going to affect me in 2050. This isn't a problem that's going to affect California or Australia or India or the Arctic. This is my house. This is where I work. And this is the sort of result that you will get. Now, there are some people on this call that will know where Indigo House in Sussex Avenue in Leeds is. And this is what the air quality is like at that address, at that postcode. It is the 94th worst in the country. So there's only 6% of places in the UK which is worse than this address in Leeds. Now, importantly, it tells me that it exceeds 3 of the WHO limits for clean air. So the first is these particulate matter. The safe limit is about 5 micrograms. This address is 13. For larger particles, the safe limit is 15. This is close to 20. And for gases such as nitrogen dioxide, the safe limit is 10 micrograms per cubic meter. This is between 25 and 30, so 3 times the risk. So we can start to see that actually the environmental impact on our patients is not their fault. Some of it is because of the society and the place that we live at the moment. So this is about bringing it home to us here now. This isn't some far off problem that we will only face in 20 years from now. This is today. Blimey, that's a bit of doom and gloom, isn't it? So we've got this critical illness that's affecting primary care. We've got problems with staff numbers falling, staff morale, burnout, staff well-being. We know that patient demand has gone up. The number of appointments that is being offered across primary care, whether that be GPs or pharmacies, for example, are going up and up. And we know that there has been a real squeeze on finances of those healthcare facilities. And here I am adding more worries. We've got these net zero targets, whatever that means, the climate crisis, the environmental impact, the cost of living crisis affecting our staff. Now, the good news is that I think that there is a cure to all of these problems. We can solve all of this, and I'm probably more optimistic this week than I was a week ago because of the UK election, because actually I think that we now have an opportunity to make some real inroads. So the plan is that if we practice and deliver environmentally sustainable primary care, that this is going to be better for our practice finances. It's going to be better for our practice staff, their well-being, their morale. It's going to be better for our patients. We're going to create health, not just wait for ill health. And it's going to be better from a planetary perspective. From a patient's health perspective, air pollution, we know that 50% of asthma is caused because of the air that people breathe. So we could eliminate half of our asthmatics, stop people from becoming an asthmatic in the first place if we had clean air to breathe. Imagine the impact that that would have on the number of hospital admissions for asthma, the number of patients, the number of inhalers that are being prescribed, etc. I'm just going to go back a step because there's a number of terms that are used when we talk about the climate crisis, we talk about greenhouse gases, we talk about net zero, and it's just to try and define them a little bit. So carbon neutral is where we still produce a lot of greenhouse gases, often through burning of fossil fuels, but we try to offset that by planting trees, restoring peat bogs, mangrove swamps, etc. So carbon neutral is where these two things would balance each other. We're emitting 100 tonnes of greenhouse gases. We are absorbing 100 tonnes of greenhouse gases. The problem with this is that there's not actually enough land on the planet to meet those requirements. We couldn't plant enough trees on the planet to offset all of the emissions. We run out of space. Equally, over the last, we tend to be burning and destroying more trees than we are planting on a global scale. And actually, tree planting needs to be nurtured, and they need to be watered, and they need to be monitored. And we know that there were trees being planted, for example, in Greece, which were then lost to wildfires last year. We know that trees get lost if they don't get watered, or if they get flooded, or if they get waterlogged. We should still plant lots of trees, and certainly from a biodiversity point of view, from a species perspective, it's really, really important. We know that mangrove swamps, for example, work as nurseries for fisheries. We know that they reduce floods, so that it's a good thing, but we can't use enough trees to offset all of the emissions. So net zero is this idea that we actually reduce the emissions from all of the sources, from all of the different things that are producing greenhouse gases, and we reduce all of them so that the actual emissions are about 80% less than they are at the moment. So this is not about doing without, and I know that there's some questions about offsetting and how far we can reduce some of the prescribing, for example, or some of our energy use. So this isn't, for me, about getting to absolute zero, which is where we don't have any emissions whatsoever. It's about that balance, so that we reduce our emissions as far as we can, and then we try and absorb those emissions that we absolutely can't otherwise absorb, stop from being produced. From an NHS perspective, what came out in October 2020 was the net zero plan for the whole of the NHS. And this was fantastic. This was great news because it started to break down what the whole carbon footprint is, what all of the greenhouse gases that were being emitted by the NHS were, and started to attribute them to different aspects, different elements. So we could start to see that there are some which are from burning of fossil fuels or from anaesthetics, and these are known as scope 1 emissions. So anytime we are releasing a greenhouse gas ourselves, that is known as a scope 1 emission. Scope 2 emissions are from electricity that is being produced that we buy. We have got control over who we buy it from. We have got control over who choosing companies based on how they generate the electricity, whether it be through fossil fuels or whether it be through wind and solar, etc. And then it breaks down the emissions into all of the other bits: medicines, commuting, inhalers, waste, etc. So the NHS, the Greener NHS, put together not only a diagram which showed where the emissions were coming from, but also how important each of those areas were. And we can start to see from a whole NHS perspective where the big hitters are. We can see certainly pharmaceutical and chemicals, big chunk of the pie; medical equipment, big chunk of the pie; building energy, big chunk of the pie. And we can also see the ones which have got much smaller slices of pie. So visitor travel, for example, much smaller. In primary care, this is about, there's approximately a 60-40 split between the emissions, the greenhouse gas emissions from clinical carbon, so from pharmaceutical, from medications that we prescribe, from the gases from the inhalers that we issue for our asthmatics and respiratory patients, and about 40% of the carbon footprint of primary care is from everything else. So things like the energy that we use, the staff and patient travel, the goods and services that we buy. Now, this year, 2024, a couple of things have come along which have started to say to us, what must I do? So from a medical perspective, so I'm a GP by background. So the GMC came out and said, in good medical practice, that we must set a specific duty that medical professionals should choose sustainable solutions. So suddenly there is guidance being given by the GMC that doctors have got to choose sustainable solutions where available, where possible, that doesn't compromise on patient care. CQC came out and said that they are going to make environmental sustainability as part of the assessment criteria. There's still details being worked on how that's going to look and what sort of things health and social care facilities are going to have to do, but it tells us the direction of travel. It tells us that this is another step on that journey of how do we deliver high quality care to our patients and not have the environmental harm that we've had up until now. So the cure, and it's not to be confused with the 1980s band The Cure, but the cure to our problems. So the question: how does practicing environmentally sustainable general practice or primary care help with our finances? And this is actually a thinking exercise that you can do on your own, and there's going to be 3 questions altogether. So when you are lying in bed awake tonight, you can start thinking, what sort of things might this include? And I'm going to give you some of the options. This is only a very short list. If in the feedback you want to know more about this, then we can work together to put on a session that goes into these in a lot more detail. But there's a number of examples. So things like changing banks, things like the energy that we use, reducing energy demand, things like increasing energy supply, so things like solar panels, looking at things like our the goods that we buy, how we use them within our frameworks, within our protocols, looking at things like waste. How expensive is waste? Are there alternatives that we can use that means that we spend less on waste disposal? So one example on banks, so this is from an organisation called My Mother Tree, and the headline says it all. Here's the good news: it pays to go green. The amount of financial return on your practice's current account tends to be greater with the banks that are most environmentally sustainable or least environmentally harmful. So there are some banks in the UK, Barclays, HSBC in particular, that are investing in fossil fuel extraction, for example, particularly harmful from a planetary perspective. They tend to give you less good return on your money than some of the other ones like the Co-op and Nationwide. So just changing banks means that you could end up with more money and less environmental impact. Well, so we've done something that's good from a planetary perspective and good from a practice perspective. That actually sounds quite good. So my mother tree, I'm not financially vested in them at all, but they have got a service that will help practices and businesses switch from one bank to another bank, and they've got lots of details on their website. From an energy demand perspective, we know over the last few years how expensive energy has been, how important it's been to try and reduce that demand. There's a thing known as an energy hierarchy triangle. Now, I'm from Yorkshire, so anything that says energy saving doesn't just mean energy saving, it means money saving. So if I use less energy, I spend less money. And as a Yorkshireman, that makes me happy. So there's things like making every kilowatt hour count. Are lights and bits of kit and equipment being left on when you're not there? I remember one of the practices I used to work at many moons ago, we had electrical storage radiators effectively that would come on overnight, charge up and then discharge the heat through the day. People may remember them. They used to be on 7 days a week. We were only in 5 days a week. That £100 timer that we put on meant that we could save 2/7 of our electricity bill in one fell swoop. So making every kilowatt hour count. Use it when you need it, don't use it when you don't. And there are things like electricity responsibility plans that practices can put into place, which basically says, this is your room, you're responsible for the electricity that it uses out of hours. So if you leave all of the stuff on, that's your responsibility. You're not using it, you're not using the room, but it's still being left on. And it can be the simplest little things. So the electronic couches, for example, which you can press a button and the bed goes up and down. They use electricity, whether they're being made to go up and down or not. Turn it off at the switch. So from a tech perspective, you can get kill switches that turn everything off in one go. You can get automation, so light sensors, for example, that only have the lights on when there's movement or when the light levels fall to a certain level. Or you can do things manually, so behavior change of turning things off. And we know about LED bulbs, and we can get low watt fluorescent bulbs. It's changing from a non-LED, you know, the spotlight bulbs, they're known as GU10 bulbs. Changing from a non-LED one to an LED one, the payback time is about 4 days. So you change bulbs on a Monday, you've recouped that expense of buying a new bulb by the Friday. So LED bulbs, if you're changing like for like from a non-LED bulb, the return on investment can be dramatic. So we're not talking 7 years return on investment, we're talking 4 days. So there's another way to have a think about things is about some of the co-benefits. So if we've got the problem at the moment of high energy bills and we want to do some actions to reduce the bills, well, of course, there is the financial gains, but there are a number of other gains as well. So we can start to think about emissions from a planetary perspective. We can start to think that wind turbines, for example, means that the land beneath them tends to not be disturbed. Under solar arrays, the land beneath it continues to have life, it continues to have animals and plants and insects and things, so we get more species that are available. So we can start to think that this isn't just good from a financial perspective in our wallet, but it's actually important from a planetary perspective too. There are a number of funding opportunities, and this will be in the guide that's available afterwards. It very much is down to where you live. There is a real postcode lottery when it comes to what is or isn't available. So, for example, north of Tyne, if you happen to be in that area, there's a Green New Deal fund. If you're in Sunderland, there's free bike stands available. But the problem is that they change all the time. So what was available last year may not be available this year, and it may well be available in a different place next year. Places that have got low emission zones, for example, that any money generated by a low emission zone, if you're in a town or a city with one, has to be spent on transport so it can't be spent on other things. So you might get lucky and get things like cycle racks and other things if you're in that area, which you wouldn't if you're not. There are some things which are available to everybody. So the boiler upgrade scheme, for example. So if you're removing or replacing a gas boiler with an air source heat pump, for example, there's financial incentives available. I'm not aware that the change of government has changed that yet. I think that it will get more generous rather than less generous. There's national lottery funding that practices have applied for successfully. There's, if you can't or don't want to put solar panels on your roof, but you want renewable energy, you can invest in a wind farm so that somebody else has got the wind farm, but you have effectively crowdsourced and you are part of it. So your energy, your electricity is coming from a renewable source because you have put your money into that rather than just spending it on higher and higher bills. And then there are things like capital allowances, which are in accountants' territories, but they effectively, as far as I understand it, will allow you to offset some of your environmental investment in your property and in your premises, which means that it doesn't feel like it costs quite as much as it did. So there's a number of ways that actually, from a practice, you can get investment in your building, in your infrastructure, part paid for by elsewhere through various grants. But it really is down to what's available locally. Can go into a lot of details about those. How might practicing environmentally sustainable healthcare improve staff morale? And again, what sort of things might you think of? Again, lying in bed awake tomorrow night, because you'll have been doing the finance one tonight. So tomorrow night, you'll be lying awake in bed thinking, how can I improve things for my staff? They've been really under the cosh over the last few years. Things didn't look like they were going to get any better. What sort of things might we be able to do in our practice that would improve that? And I do not mean buy them pizza once a year and think that that's going to cut the mustard, because it genuinely doesn't. But there are a number of other things that can make a big difference. So things like shared green spaces, shared gardens, things like lift sharing. I will tell you something really useful from a lift sharing perspective. Things about activity and things about group consultations. So this is a practice not that far from me in North Yorkshire. This is, they had £100, which wouldn't buy you very much pizza. And this was 3 years ago, and they are still getting staff morale benefits from it today. So basically they went and saved a number of dying plants. They got some consent. They turned effectively an unloved space into something which is far more beautiful. They've now got an area that they can sit in at lunchtimes when it doesn't rain quite so much. They've also improved, the number of plants, the number of flowers. They've helped pollinators. They've started making it look eminently more attractive. They got staff camaraderie in planning it, doing it, and now using it afterwards. And I would challenge anybody, if you've got £100 budget to do something that will last 3 years and give this many people this much pleasure and improvements in morale. Lift sharing is actually something which is really, really, really useful. And this actually came about from a practice manager talking about complaints that they were having in a car park, that there weren't enough spaces for patients, and patients were complaining. So we were talking about, well, how can we solve the problem that you've got of patient complaints? So we started having a look at how could we improve car parking. Well, one option is let's tarmac over some more green space, let's build a bigger car park for people. But actually that wasn't appropriate for a number of reasons. So we started looking at, well, could we change the way that staff travel? And particularly because a lot of staff all came to work on their own. So we plotted where the staff live, and we asked them, what would enable you to lift share? And the number of them that said, we would love to lift share, but our shifts just don't start and finish together. That the receptionist and the admin and the secretary and the healthcare assistant all wanted to come together, but they all started or finished at different times. So the practice manager changed the rota, And there were a whole host of things that came out of this. From a practice perspective and a practice manager perspective, the car parking problems disappeared. They got less complaints. That was what they really wanted us as a practice manager. From a planetary perspective, we took cars off the road because we had people sharing cars. So actually, the air quality got better, that there were less emissions, whether they be greenhouse gas emissions or air pollution. But the staff were the ones who really, really enjoyed it because they were friends outside of work. Actually, they got to spend more time with each other traveling. So they got an extra 20 minutes coming to work and an extra 20 minutes going home, which meant that they could chat, which meant that they could share the stories that they were otherwise sharing in the workplace. And they actually felt more comfortable being able to have those sort of chats outside of work rather than, but this is on work time, we should really be working, we shouldn't be building camaraderie and staff morale. So they got more time together. They also got lower fuel bills, so we were addressing that cost of living crisis because they were putting a quarter of the amount of fuel in their car because there were one car being used instead of 4. So actually, we could start to tackle lots of different things all together because the practice manager recognised that the answer to the patient complaints was not building another car park, but by doing things differently. How much did this cost the practice? Nothing. It was changing the rota so that they started and finished at the same time. So these sorts of things can be really, really, really useful. Being an active practice, this can be remarkably important from a staff morale perspective. So parkrun practices, parkrun is an initiative where people locally run 5k and practices can basically get involved, do some of the marshalling. They can do some social prescribing and they can see patients who being physically active because they're being those role models. And actually, it promotes the health and well-being of staff and patients, and it improves staff morale. One of the things that makes a difference, the difference between an inactive member of staff and an active, physically active member of staff is about a week's worth of productivity a year. So if you want more out of your staff, one way to do it is to enable them to be physically active, whether that be through parkrun, through active commutes, or a whole host of other initiatives. Active people tend to take less time off of work with ill health. They tend to be more productive in the workplace. So if we want our practices to be more efficient, one way we can do that is by increasing and improving physical activity. And some of these things also improve, as I say, staff morale. How does one of the things that we've been overwhelmed with over recent years is patient demand. So how could practicing environmentally sustainable general practice help with patient demand? Again, this will be for the following night because you'll have had the next 2 nights thinking about the first 2 questions. So third night, you're lying in bed, you're thinking, well, how else can we reduce our patient demand? Because we just feel overwhelmed at the moment. There is no magic bullet to this, but there are a number of things that can make a difference. So appropriateness of prescribing and deprescribing, really, really important. The importance of one-stop clinics. I'm still surprised and amazed at surgeries that invite people back more frequently than once a year for an annual review, because they get an annual review in diabetes, and then they get an annual review the following month in heart disease, and then they get an annual review the following month in COPD, and the patients are coming back. The patient demand is going up because we're not being efficient. One of the things which has been important over the last few years is looking at the types of inhalers that are used. So metered dose inhalers have got a fluorinated gas, which is particularly powerful in terms of its global warming potential and particularly harmful from a planetary perspective. There are dry powder alternatives that don't have any of those propellant gases in, which have far, far, far lower carbon footprints. So from a patient perspective, it's about finding the inhaler that works best for them. And when you start looking at how well do people manage the metered dose inhaler, what people know as the traditional inhaler, is actually quite badly. They are not well designed for patient use. More patients can manage the dry powder inhaler than they can the metered dose inhaler. But in this country, we've continued to prescribe the metered dose inhaler. We've got one of the worst rates of deaths from asthma in the UK compared to many other parts of the world, for example. Whether it's directly relatable to the types of inhalers that we use and how well controlled our asthma is, I don't know. But certainly we know that there are patients who do far, far, far better on dry powder inhalers than on metered dose ones. And this is particularly true if patients are being given both. So not only have you got to learn and perfect one inhaler technique, but you're being asked to do 2 different inhaler techniques because the delivery device is different. That's just crackers. So if we can get our patients to use the dry powder inhalers well, actually it opens up easier to use, better control, less environmental impact. And there's some great resources from Greener Practice on their high quality, low carbon asthma toolkit, which gives practices everything that they need to know, down to what could we put in the text message that we send to patients, how do we identify patients, where's the inhaler technique videos, etc. Anticholinergic burden is something which is, again, really, really important. Anticholinergic burden is a side effect from some medications, and the more drugs that you give with this risk, the more problems that it causes. I had a patient in whom I thought I was doing the right thing and gave them a whole host of drugs for a whole host of different conditions, and eventually they ended up falling, getting confused, becoming housebound, becoming isolated, not being able to take their dog for a walk, all sorts of other side effects, because effectively I was accidentally poisoning them. And the best thing that I could do was review their medication and stop the stuff that they didn't need. And it was almost like Lazarus. It was a resurrection. This lady suddenly started being able to take a dog for a walk again, and the things that were important to her in her life. So from a medical, from a pharmaceutical, from a pharmacy perspective, these sorts of things are really, really important. We know that about 6.5% of people are in hospital at any one time because of drug interactions. I didn't quite end up putting this patient into hospital, but if I had, it would have been because of me and my prescribing. So it's really important that we're not adding burdens to other part of the health service. We're not adding to demand elsewhere because of our prescribing habits. Group consultations are something which is becoming increasingly useful. So we've got things like improving staff morale, improving job satisfaction, partly because we can see more patients, we offer a better quality of care as a result, and we actually can prevent burnout. And there's an increasing number of resources that are available for this. Well, but won't this increase my workload? Well, actually, overall, no, it won't. We still have an electricity company supplying our practice. It's just a different one. We've made one phone call when our a contract was up for renewal, and we've swapped. We've changed our bank. We had one phone call to My Mother Tree or other organisation. They did the hard work. They did the legwork for us. We now have more money in our bank. We've got less environmental impact. We've done one change once. So actually, no, it's not. We still travel to work. We just happen to all do it in one car now instead of 4 cars. So we've reduced our workload because we're only driving a quarter of the time. So this is more about swaps and substitutions. We're still treating asthma. We've just done it using a different inhaler. It's about changing things. And one of the really important things is actually just writing this down, putting into a practice green action plan, what the action is, who's going to do it, when are you going to do it by. Actually, it starts to focus the mind. I'm going to do this by next week, by next month, by the end of the year. I'm going to change my bank account in the autumn. This is the number I need to phone. This is how I'm going to do it. And it gets done. And there are a number of things that are really, really important for all of us that we can do. So from an environmental sustainability perspective, these are the things that I would suggest. So Catherine Hayhoe is an American professor who really talks about the importance that each and every single one of us has got. So talk to other people. And I can see that there's a few people's comments popping up in the chat. I know that I've talked to a number of you about these sorts of things. Talk to your friends, talk to your family, talk to your neighbours, talk to that person in the pub, talk about the things that are important to you. Tell your story. I can tell you about the image that is behind me on this call at the moment. These are the green fields of Yorkshire. This is where our bread gets grown, for example. This is why I want to protect and look after the natural living world, because I want to look after some of the green spaces that we've got. Finding other people, not an echo chamber. They can be dangerous for a number of reasons, but people that you can bounce ideas off, things that you can talk to people and get support from. Become aware. Know that none of us know everything at the moment. We can do as we do well today, but if we learn more, we can do better tomorrow. One of the really important things is about spreading that word and using your voice, using your influence with other people. And for me, it's far more important that we act and we do something and we show other people that we're doing it than we just don't do anything. So even doing the little things can help inspire other people. And that's it for me. So I'm going to switch off in just a second and move over to the questions. But there are a number of things that myself and Helen and the team would like to know. So if you would like to know more about the finances, more about the staff morale and well-being, more about how to improve patient health, there's a feedback form that will be coming. If there are specific questions, we can put on webinars, we can put on Q&As, we can do really whatever works best for you. What do you want to know about? How will your lives become easier, richer, more fulfilled, and less environmentally harmful? And so I'm going to stop sharing at this point and say hello, Helen.
Thank you very much, Matt. I have got quite a few questions that were submitted, but first of all, I just wanted to mention a comment from Richard Podmore in the chat, who has implemented changing the inhalers of the patients. Richard, I don't know if you'd be happy to speak up and just, to tell everybody else how you went about that, just to give people advice if it's something that they're interested in doing.
Hi, Matt.
Hiya.
No, it's great. It's good. It's really good to see the, how clearly you describe all of the benefits and the sort of no-brainers, it is for us to take this action and to make those changes. But Helen, I didn't do any of this. I'm just merely the mouthpiece for all of this great work that happens at Froome. The meds management team, so one of our clinical pharmacists, has been working predominantly on inhalers in sort of her non-clinical time, so in her project time, and has been looking at different ways to move patients from metered-dose inhalers to dry powder inhalers where it's appropriate. They've so this group of patients we looked at, or Jill looked at, were patients that hadn't been previously offered a switch to a dry powder inhaler, and were currently using a metered-dose inhaler. They were switched via text message with some sort of safety netting as well. So there was nice guidance attached to the text message, and they had an opt-out response as well for patients to follow as well. And then they were followed up at the 1 month mark as well to make sure that they were happy with their switch. Those patients were then followed up a year later to see if they were still on dry powder inhalers, and they were. We've got a poster on that we shared recently at the Share conference, and we can happily share that as well if that's useful to you.
Thank you, Richard. That's great. Can I just ask something at this point? As a patient who uses inhaler, can patients go and request this? Like now that I know this information, could I go and request to change that based on what I've learned today?
That's what I did about 7 years ago When I
Yeah,
learned about the environmental impacts, I went to my GP at the time and asked to be changed,
right.
and if it was
Brilliant.
appropriate.
Thank you.
All healthcare should be a conversation between the patient, what their needs, what their hopes, dreams, aspirations are, and what healthcare can provide and deliver. And if you are one of the 95% of people who can manage the dry powder inhaler and it works for you and your respiratory condition is well controlled, absolutely. I think that if we went back to the 1960s and saw what healthcare was and you are told what to do and how to do it, I really hope that those days are absolutely extinct. So it should be a conversation, and absolutely, you, your GP, your pharmacist, your specialist nurse, your practice nurse, absolutely have a conversation. Talk to them about what's important to you. Tell them your story about why it's important, and then you do it.
There has been a couple of other questions around prescribing, Matt, so I'll ask those now. So the first one, how far can we realistically reduce our prescribing related emissions? Should we all ready ourselves to offset, or should we be thinking of other strategies?
Yeah, absolutely brilliant question. So there's a new tool that has come out called the Medicines Classifier, and I will try and just multitask and put that in the chat as well. So there are, just give me 2 shakes of a dog's tail, go to formulary, here we go. So this is for anybody who is involved in prescribing. You can now see what the carbon footprint is of any medication, any tablet or capsule that you can prescribe. So you can see what has got a high or a low carbon footprint. Not yet, but that will start to inform our decision making. So if you had a number of different medicines to treat the same condition, some of which had a very high environmental impact, some which had a very low one, but clinically had the same outcomes, then you can see why we might end up saying, well, we're going to use that lower carbon or lower environmental impact. So how far can we go? Well, 80% of, it depends on how far you want to go with this. So 80% of chronic disease could be prevented. So I've already mentioned 50% of asthma. We start looking at things like diabetes. What proportion of type 2 diabetes could we prevent if we had diet and lifestyle that was appropriate? About 95%. So in terms of medicines, do we need all of the medicines that we are currently prescribing if we had a fitter and healthier population, if we had a society that enabled active travel, healthy diets, all the rest of it? So we don't need the medicines in the first place. And then we've got ways such as those metered dose of dry powder switches, which are about 5%, give or take, of the footprint. So we could get a 95% reduction in footprint and still treat all of the asthmatics and respiratory patients well. In terms of other medication, don't know all of the answers yet, but so one of the things that you will see on UMaker is that there is a preprint paper which shows that antibiotic prescribing is particularly, it's got a high carbon footprint. We also know that where antibiotics are used appropriately, they're the right thing, but they often get used inappropriately for the wrong length of course and all the rest of it. So by doing things better means that we get less patient side effects, interactions, lower carbon footprint, better outcomes for patients, better outcomes from a planetary perspective. How far could we go? I think that with a fair wind, we could probably get a 50, 60, 70, 80% reduction in chronic disease and knock-on effect on the environmental impact of the treatments. But I'm an optimist.
Thanks, Matt. Somebody's asked about how to cut paper waste and printing, and how do they go about going digital in lots of different aspects.
Yeah, absolutely. I think that whereas paper and going digital is useful, it's not going to solve all of the carbon footprint of healthcare. It is a small fraction of it. There are some practices that effectively, so a practice of 20 staff may have 20 printers. There are some practices that will reduce that number to 2, Basically, one is being used and one is on standby. Everything is digital. There are practices that are absolutely paper-free now. The paper comes in the front door, is scanned on, and is disposed of at that point. That there isn't printing done in the practice. Because what are we printing out? And almost all of the things that we print out can be done digitally. That's not true for everything, but it is true for the vast majority. There are certainly new bits of tech and new bits of kit that allow and enable summarising of hospital letters, for example, automatically. There are things that will automatically summarise the patient consultation. These are things that didn't exist a few years ago. So certainly when it comes to cutting down paper, doing a paper audit, and I'll talk about waste in a second and doing a waste audit, but doing a paper audit, we bought 10 reams of paper. What have we actually printed? Were these patient letters? Or could we have done that differently? Were they patient records? Could we have done that differently? And it's identifying what you're using that paper for and then saying, what is the alternative? And there's not one size that fits all. And certainly from a waste perspective, doing a waste audit can be really, really helpful. And a waste audit is basically going through the rubbish bins and finding out, was it appropriate? Is it put in the right place for the right reason? Is this recyclable? Is it not recyclable? Is it hazardous waste? Is it non-hazardous waste? So generally, the infectious waste is really expensive to dispose of financially, really expensive to dispose of from an environmental perspective. At the other end of the scale, stuff that is recyclable tends to have the least cost and least environmental impact, least carbon emissions. So the more stuff that we can get to recycle, the better. Even better than that is looking at some of the clinical pathways and saying, did we need this thing in the first place? Have we just generated waste because we bought something that we didn't need and we've just ended up putting it in the bin? Is there a way that we could have done this thing without generating the waste in the first place? And there's all sorts of, why buy a plastic bottle of water when you've got a tap of water? You've not generated the plastic bottle by using the tap. So waste audits, electricity audits, paper audits. What is creating or using or generating some of these things? And it's only when you start looking at the details can you suddenly say, we don't need to keep doing it like that. We can do it differently.
Well, somebody's just added a question in the chat, Matt. Do you want to have a quick read of that?
Yeah. Any thoughts on eliminating single-use plastic items wherever possible? Single-use tourniquets, which our organisation says are necessary for infection control. And looking at any good resources that have looked into the NHS footprint with single-use items and offered suggestions for more sustainable alternatives. Absolutely brilliant question. So yes, there are two resources that I would go to. The first is there's an amazing lady called, I think probably Dr. Chantal Risen from Brighton. She's a medical doctor and a PhD doctor. She has got a website called healthcarelca.org. I'll put that in the chat. And this is basically every single paper that has been written about healthcare products. Let me just see. I'm trying to do two things at the same time, you see. I cannot multitask.
We can put that in.
Yep, healthcarelca.org. So all of the papers that have been produced with a life cycle assessment of healthcare stuff. So if you want to know is there a paper on catheters, on ECG machines, on whatever it is, then that's the place that I would go. She's an amazing person. If you ever get a chance to hear her talk, that's where well worth it. The second is the Centre for Sustainable Healthcare, the CSH. They have got a lot of resources. They do green competitions, which looks at how can we remove gloves, tourniquets, all sorts of other single-use items. There's just been a project specifically on single-use tourniquets and being replaced with multi-use ones that basically are wipeable in between patients. So certainly from a primary care perspective, there are ways that working with infection control rather than against them means that there are good examples of these things happening elsewhere in the country. Fantastic. Thank you very much, Nuala.
Okay.
This is the beauty of being on a call like this, is that there are people who are busy searching in the background because they know the answers to some of these things. There you are.
Yeah.
Fantastic.
So we've got just a couple of minutes left, Matt. So I'd just like to ask if anybody's got any other questions, if you'd put them in the chat. We might not have time. We're probably not going to have time to answer now, but we will answer them in the guide. So just finally, I'm going to put the link to the feedback. Would really like to hear if you'd like more information from Matt. So whether that be another webinar on a specific topic, or whether it be a workshop that we could deliver locally. If that's what you want, we can deliver it, but we'll really need to know that. And I'm going to put the feedback form in now. But just quickly, Matt, we've had a few people say this, and I know you've given us already lots of tips on what we can do for quick wins. But what are your top 3 tips for quick wins in primary care in general practice? Yeah.
I'm going to combine that with one of the other ones, which says, is it important to have a green champion? So for me, absolutely the first thing is talking to people, talking to staff, getting them on board. What's important to them? So a quick win is talking to them. Build up your team. This is your tribe in your workplace that actually will make all of everything else a lot easier. And then it's going with the energy. So if the energy is looking at single-use plastics, looking at energy use, looking at travel to work, great, go there first. If it's waste reduction, go there first. If it's paper, go there first. So sometimes they might be smaller in the grand scheme of things, but actually you've shown the rest of your team that this is important. You've wanted to do this, so we've done it. So we've worked together, we've got a great result on waste reduction or energy savings or whatever it is, then, okay, what can we do next? So I think that the next is not stopping at one thing and saying, oh, that's it, I've done it now. I've stopped using single-use straws, therefore it's all good. So in terms of quick wins, build your team, talk to each other about what's important, find where the energy is in the room, do that, and then move on to some of the bigger and brighter things, and you start motivating and encouraging and enthusing people. If money's the most important thing, have a look at some of the co-benefits of the actions that you can do that are both good from a planetary perspective and a financial perspective. If staff health and well-being is most important, you know what I'm going to say, do the things that are going to make a difference there and less environmentally harmful. Or if it's about patient demand, patient outcomes, patient health, health creation, go there.
Great. Thank you very much, Matt. Well, obviously, we want to keep the time just because we know everybody's really busy. So again, thank you very much for spending your lunch break with us here today. We hope I answered all your questions. Yeah, and thank you very much. Look out for an email to follow with all of the information we've covered today. And thanks very much, Matt. It was really very interesting, and I've learned a lot as well. So thank you for that.
And thanks to everyone who's given up their lunch hour to be here.
Yeah,
much appreciated.
Great. Thank you very much. Bye now.